Okay, let's get started. Welcome to our second annual University of Michigan Injury Prevention Center Research Symposium abstract section on suicide prevention. I am Dr. Cheryl King, a professor of psychiatry at the University of Michigan Medical School, and I'll be moderating this session. Thanks for joining us. We're really glad you're here this afternoon. And before we get started, I'd like to share a bit of information about the session logistics and about how Q&A will work. First, as a reminder, this session is being recorded and only the presenters and moderator will be visible. Second, the chat is disabled, so please use the Q&A function for all of your questions. If you do have a question for our presenters, please ask by typing it in the Q&A feature in your bottom menu bar at any time. And please indicate who your question is for by including their name at the beginning of the question if you mean it for a particular individual. We will have Q&A after all the abstracts have been presented, but we encourage you to send in questions throughout the session so we can have a chance to review them. We'll answer as many as time allows. Third, our presenters will have 5 minutes each to present their abstracts. We'll share their slides while they're presenting, and all of the abstracts can be found on the Center's Symposium webpage. Finally, there are 3 other abstract sessions happening at the same time as this. And of course, as much as we'd like you to stay in this one and listen to these great presentations, we welcome you to visit other sessions. Please feel free to do so. Recordings of all the sessions will be released in the coming weeks. Now join me in welcoming our abstract presenters. I'm going to introduce everyone now so there's no interruption in the flow of presentations. We're going to go slightly out of order today due to a scheduling issue. First, we'll have Ching Feng from the Health Systems Program, Department of International Health, Johns Hopkins Bloomberg School of Public Health. Then Adam Horowitz from the University of Michigan Department of Psychiatry, Yoni Seiden from the University of Michigan Medical School, Khaled Atia from the University of Texas Medical Branch School of Medicine, Lindsey Bornheimer from the University of Michigan School of Social Work and the Department of Psychiatry at the Medical School, Nicholas Martinez from the Texas Tech Health Science Center, El Paso, and the Paul L. Foster School of Medicine, Steve Stack from Wayne State University and the Center for Suicide Research, Tatiana Quinto from the Catholic University of Santos, and Ching Feng, who I mentioned at the beginning, and he's going to begin for us. Presenters, when it's your turn to present, please turn on your audio and video and then turn them off after you're done. Okay, we'll begin sharing the presentations and get started.
So hello, everyone. My name is Jim Li. I'm assistant professor at Johns Hopkins Bloomberg School of Public Health. Today, I'm presenting on behalf of our team. This work, as you can see from the slide, this work is part of a project funded by Foundation Martinez, and we also acknowledge the support from UNC for granting us access to their health data. So this is the teamwork that we have been doing for the past almost half year. So our aim is to predict adolescents at high risk for suicide using machine learning methods. So the eventual project size will be in 2 developing countries, Vietnam and India. But we are doing this part of work for validation. We can validate this approach in a setting where we can get access to rich data. Next slide. That is our objective. Currently, we are using data from at house, and that include adolescents in grades 7 to 12 in the United States. The data was pretty old, collected about 25 years ago. We are using data from 2 waves. Basically, we are trying to use information from wave 1 to predict the outcome in wave 2, so that you can see this is the prospective prediction, right? Our outcome is suicide ideation, and we are using a large number of predictors, and then that are selected from hundreds of variables. If you are familiar with that house data, you know they have rich information. So that is our work. We screened more than 3,000 actually predictors, and then we selected a subset for our final model, and then we use the model, we use the data to predict. We have tried several machine learning approaches, including lasso and also SVM. And today we're going to present our result from random forest algorithm. And that is some of the procedure that we've done: variable selection, model tuning, sensitivity analysis. We're also going to focus on predictive performance today. Next slide, please. So first, on the left, you can see our descriptive statistics that show the data in wave 2. You can see about 10% of the adolescents showed some suicide ideation, and then that is also distributive statistics from wave 1. On the right, you can see this is the result from the random forest, and they show the relative importance of the 19 predictors that are currently included in our model. You can see ranked number 1 is the parent education, second one suicide ideation last year, which means the last wave, and also parent health problem, BMI, and other depression. So many of the predictor has been identified in previous literature, but here we just show this also important predictor. So, and on the bottom, you can say this is the typical ROC curve. And then you can see the AUC, area under curve, is reasonably good. It's 0.72. This is comparable to other high performance models. Next one. This is our last slide. You can see our current conclusion is that our results show the potential for machine learning to help us to identify high-risk adolescents. And then, of course, the goal is that we can take intervention before the adolescent, before the injuries occur or suicide occur. There are some limitations, and also we have the policy implication that's pretty important. As you know, that suicide is almost leading, at least ranked very high in many settings, particularly in low-income countries. For example, in Vietnam, we know it's ranked number 2 or number 3 for adolescents. So unfortunately for today, I may not stay here for the Q&A session. If you have any question or interest in learning more about what our study, please feel free to email me so that we can keep the conversation. Thank you very much.
All right, hi everybody. My name is Adam Horowitz. I'm a clinical psychologist and assistant professor here at University of Michigan. And today, happy to talk with you all about a project we recently completed called Daily Mood Diaries and Wearable Sensor Data as Predictors of Depression and Suicidal Ideation Among Medical Interns. I want to acknowledge my co-authors on the project, Eva Sis, Nadia Al-Dahani, Walter Dempsey, Joan Zhao, Inbal Nahum Shani, and Srijan Sen, as well as funding from the NIMH and NCATS. So one of the big kind of reasons why we're interested in doing this study, so there's been a large growth in intensive longitudinal methods to predict suicidal ideation and depression and other mental health outcomes in the past 5 to 10 years in particular. And a lot of those studies have really used these either very clinically severe, very small samples, or sometimes just have a very high participant burden where folks are completing these surveys upwards of 6 times per day. And there were some questions about how does this really look like if we were to extend this out and generalize it to other more naturalistic real world types of settings? So next slide. So for this project, building on the intern health study, which is a longitudinal cohort study of medical interns beginning their first year of residency. Past cohorts of the study have demonstrated that interns develop quite a bit of depression and suicidal ideation, particularly during the first quarter of residency, given high stress and transitions to new places and a lot of pressure. And so this presents a unique opportunity to really examine that onset of those symptoms. And as part of the intern health study, they're provided with Fitbits prior to joining internship and complete some clinical and sociodemographic surveys prior to the start of internship. Again, we mail them the Fitbits, and then during internship, they're completing these very simple one-item daily mood ratings, which you see in the graphic there on the side. And so what we were really interested in was seeing whether or not we could use some of this more kind of passive data from the Fitbits, as well as these daily diary surveys, to predict which individuals might be developing depression or who's going to have suicidal ideation at the end of the quarter. So we developed these 3-step hierarchical logistic models predicting depression and ideation at the end of the first quarter, and included those pre-internship characteristics in the first step. So things like their PHQ-9 depression score and presence of ideation prior to internship, neuroticism, age, sex, things like that. Step 2 included features from the Fitbit, so things like their sleep and steps, how much it's changing, as well as then in the third step, their daily mood diaries, both their mean scores as well as variability from day to day, as well as completion percentage, and there were some other metrics we examined as well. Next slide. And so, again, we were most interested in that incremental piece. So for space sake, we didn't include the significance of those first steps that had the pre-internship characteristics. But on the left-hand side, you can see this prediction of depression. And in the second step, when we add the Fitbit features to the already quite significant model, not a whole lot of improvement, quite small, just very marginally significant, mostly driven by improvement related to sleep mean. Those who were sleeping less were more likely to have depression. But in that third step, we did see a pretty significant increase, both in the overall model accuracy with the area under the curve, and that was driven by both the mean scores as well as the variability scores. As it pertains to suicidal ideation, on the right-hand side of the table, Fitbits provided absolutely no added benefit, weren't predicting anything. However, again, we did see those daily diary mood scores, both the mean scores as well as variability, did have a significant improvement to the model accuracy driven by those two features. Next step or slide. So yeah, so main points are that, these daily mood diaries, single items assessed kind of over this naturalistic period of time. Individuals weren't compensated for completing the surveys, weren't compensated for wearing their Fitbits, but adherence was generally quite high. And so we were able to make a pretty substantial improvement in the prediction using just these features. However, unfortunately, like the more exciting thing would have been the Fitbit aspects. Unfortunately, they didn't come through, but over time, these continue to get more sophisticated, and we're hopeful that there are features there that will help provide a better sense of improving this prediction accuracy, which has significant implications for adaptive interventions where we can detect changes in their movements or in their sleep or in their daily responses, and then provide a resource, information, skills, coping tools, etc., for those who might need it. So I will stop there, and if there are any follow-up questions afterwards, my email is there. Otherwise, happy to answer in the Q&A or at the very end of the session. Thank you.
My name is Yoni Seiden. I'm a medical student here at the University of Michigan Medical School and also dual at the Ford School of Public Policy. Today I want to talk a little bit about equity analysis we conducted of burnout and mental health to target well-being programs here at the medical school. We know that medical students have higher rates of depression than their age-matched peers nationally, and that a shocking 1 in 10 experience suicidal ideation over the course of their medical training. We also know that burnout appears to be correlated with suicidal ideation, making it a very worthy place to begin seeing if we can intervene on this problem. Unfortunately, institutions really lack mechanisms currently to target programs to marginalized groups. And so the question that we sought to answer was, can we use existing data that's already present at our health system to better understand how to better target these programs? Next slide. To do this, we reanalyzed content from a treatment access survey that had been conducted in the summer of 2020 with all medical students and recent graduates via Qualtrics. That survey collected 3 well-being indices: burnout at the time of the survey, concern for one's emotional well-being at any time during medical school, and concern for one's own mental health at any time during medical school, which was self-defined mental health. We collected limited demographics, just class year, gender, and race and ethnicity. I constructed a composite variable looking at races underrepresented in medicine, which I'll refer to as URIM, as well as an interaction variable of URIM and cisgendered women. I ran statistical tests, including odds ratios via logit regressions that use robust standard errors to account for heterostaticity, and I graphed the residuals to assess for normality, all of which were appropriate for the testing. I conducted univariate and multivariate tests, but will only present the multivariates today. Next slide. So what did we find? Well, about half of our students were burnt out at the time of the survey. This actually conforms to national data. We found that cisgendered women were had a 3 times greater odds than cis men of being burnt out. When it came to emotional well-being, a shocking 86% of our students experienced concern for their emotional well-being at any time during medical school. When we broke it down by demographics, we found that cis women had a 7 times greater odds than cis men. We also found indicators that showed that cis women of a race URIM, trans students, and Latinx students of all genders may have a greater odds of burnout, but these were highly imprecise measurements with very large confidence intervals. When it came to mental health, we found that nearly 3/4 of our students had been concerned about their mental health at some time during medical school, and that that the odds for women was 5 times greater than the odds for men. Next slide. So the question is, what do we do with all of this information? I think what's clear is that we really need to direct initiative towards cis women, and we need to explore the needs of cis women of color, transgender students, and Latinx students. But the place that we really found important was that we need to improve our data collection. We need to consistently collect demographic variables at all surveys coming through our institution, and these need to be comprehensive and standardized. For instance, in Southeast Michigan, we have a very large Arab and North African population, and yet these students were really not represented in our survey because we didn't ask the question. We also know that sexual orientation is correlated with poor mental health outcomes during training, but we didn't ask about that either. We need to do a better job. We also need to prioritize equity analysis in program design and evaluation. It's clear that not all students experience burnout or well-being the same, and we need to better understand how to target and shape our programs to meet their needs. I really look forward to hearing your feedback. This is a new initiative at our medical school and excited to learn together. Thank you.
Hi, my name is Khaled Atiyah. I'm a student, medical student at UTMB here in Galveston. And my project is increased risk of suicide from manic episodes following COVID-19, multi-institutional analysis of 4,926 patients. Next slide, please. So for the methods, we used Trinex and we looked for the presence of SARS-CoV-2 infection by these following codes right here. And mania was determined by the ICD-10 code F30 corresponding to a manic episode. So we had 2 cohorts. One of them, patients were diagnosed with a manic episode within 3 months of a COVID-19 infection. And the other group was patients that were diagnosed with a manic episode without a history of COVID infection within the last 3 months. So the cohorts were balanced for age, race, gender, and ethnicity, and 2,463 patients were in each cohort. And we compared the outcomes for suicide attempt via ICD code T14.91, which we limited to 6 months post-infection. Next slide, please. So the results were that patients experiencing a manic episode within 3 months after COVID-19 infection were 2.1 times more likely to attempt suicide within 6 months of infection compared to patients experiencing manic episodes that are not temporarily connected to COVID-19. So we deduced from that, and there needs to be more research done, of course, but there is some correlation between the inflammatory infection process that happens when somebody catches COVID and the way that it interacts with the mental state of patients that are suffering from bipolar disorder. Next slide, please. And so, yeah, that's our conclusion, is that 4,926 patients suggest that bipolar 1 patients who experience a manic episode within 3 months of COVID had an increased risk of suicide attempts. Next slide. I think that was the last one. Yeah, thank you.
Hi, I am Lindsey Bornheimer, and I'm an assistant professor in the University of Michigan School of Social Work and Department of Psychiatry. I will be presenting on technology use in a NIMH-funded R34 study that I'm leading of a suicide prevention treatment for adults with psychosis in community mental health. I'd like to acknowledge our funder, the NIMH, and my co-investigators, Dr. Cheryl King, Stephen Taylor, and Joseph Himley. Next slide, please. Suicide is among the leading causes of death for adults with schizophrenia spectrum disorders. And this R34 study is aiming to modify and test a suicide prevention treatment tailored for adults with psychosis. And we know that time is a significant barrier to provider training, and the use of technology can increase accessibility, convenience, and engagement. And it also can be useful for clients in treatment and provide a bridge between sessions. So today I'm going to describe our technology-focused modifications, which include the development of a virtual and on-demand provider training and between session engagement enhancers for clients involving weekly text messages and 10 weekly videos. So our approach to modification involved community-based participatory research methods, where we collected and analyzed mixed method stakeholder data with 25 clients, providers, and peer advocates at Washtenaw County Community Mental Health. We then gained input from scholarly experts in the fields of suicide, psychosis, intervention, and implementation science research. And ultimately, we developed the technology-focused modifications. Next slide, please. Provider, stakeholders, and experts agreed that virtual training would be feasible. They recommended the use of cohorts in training. They also wanted more opportunities for real-time questions in our on-demand training. They wanted live role plays and several other things as well. As anticipated, barriers to virtual training included time constraints, competing demands, distraction, and buy-in. All stakeholders and experts agreed that weekly supportive and content boosting text messages and videos could really help with client engagement between session, but they also recommended that we keep the content very simple and the videos short. And as anticipated, barriers to texts and videos included, again, concerns about technology access, concerns about psychosis symptomatology, motivation, and many other things as well. So on the right-hand side of the screen, you'll see some screenshots of the technology we developed. So our provider training is currently in Canvas at the University of Michigan. Our client videos were made using Beyond software, and the videos are weekly. They follow a character you can see on the screen a bit, Andre, and you see him go through treatment. We learn about his story, see him face challenges, and apply skills that he learned in therapy. Next slide, please. So our stakeholder findings point towards the potential benefit of using technology to train providers and increase engagement with clients. Addressing technology barriers really has the potential to increase provider access to innovative intervention training and also enhance client engagement in service delivery. CBPR methods were really essential for us as we informed our technology modifications. And this is particularly so given in this population, there's a lot of stigma, marginalization, health disparities, and we often see very low service utilization rates. As for our next steps, we are going to explore the feasibility and acceptability of these technology-focused modifications in an upcoming AIM-2 randomized control trial. Thank you very much for your time and interest in this work, and I look forward to any questions.
Hello, everyone. My name is Nicholas Martinez. I am a third-year medical student at Texas Tech and Apollo Foster School of Medicine. And this project is looking for an association between suicidality and delirium that's been induced by COVID-19. So this is a multi-institutional analysis of almost 120,000 patients. So next slide, please. So before I go into the methods, I just kind of wanted to explain the reason for this project. So going through clerkship right now and going through rotations and working with patients, working with doctors, you're always kind of told about how suicide and suicidality it's pretty pervasive, and you see that firsthand, or at least I'm, in my personal experience, I've seen that firsthand, and I kind of got interested in its relationship to COVID-19 since the pandemic still hasn't gone away. It is here, and it seems to be here to stay. So COVID-19 is known to cause pulmonary dysfunction, but it's also a virus. It's an infection that can cause other dysfunctions in other organ systems. So it's known to cause cardiac dysfunction. It's known to cause hepatic dysfunction. And so my interest was to see if there was also a mental health aspect associated with this, hence the association with suicidality. So the methods that were incorporated for this project, we used Trinetics. So this is a global health network. It allows you to look up ICD codes related to patient conditions in hospitals, has a large amount of healthcare organizations involved, I believe over about 64, and about close to 100 million patients now in their database. So it allows you to kind of look for a lot of information across the entire country. So what we did is we planned to separate patients into two cohorts, those who had delirium not associated with COVID-19 and those with delirium associated with COVID-19, and then following up to see the rates of suicidality in each group or cohort. All the information that we've obtained has been de-identified through Trinetics, following HIPAA privacy rules. The presence of SARS-CoV-2 was determined by looking at certain laboratory codes, which are 9088 and so on, which correspond to the detection of the SARS-CoV-2 RNA in the patient's blood. Delirium was determined by ICD codes 10 F05 R41.0, and the two cohorts that I had mentioned before were separated out, and each cohort had about 60,000 patients in each, and they were balanced for age, race, gender, and ethnicity. Next slide, please. So the results of the study showed that patients who had delirium induced by COVID-19 infection had a 1.35 times higher likelihood to attempt suicide compared to the other group who were experiencing delirium from another cause that was not COVID-19. And the p-value there was statistically significant under under 0.05. And the data collected was from over 119,000 patients, and showed a positive association between an increase in suicidality in delirium from COVID-19. Next slide, please. And so, like I said before, the association seems to be there. It seems that there is a significant risk factor for suicide and suicidality in patients who survived COVID-19 infections. And really, my hope for this project is that it opens up other avenues of research to look for potential causes for this finding. because this was just kind of a scan of patients who had COVID-19 delirium and then experienced suicide afterwards. So the interest is that we kind of delve into this further to find out, well, what exactly is the reason for this increase in suicide, particular to COVID-19? So thank you guys for listening. I'm looking forward to answering and hearing your questions, and that'll be it for me. Thank you.
Oh, hi, I'm Professor Stack. I'm retired now from Wayne State University. Our paper, co-authored with Ian Rocket, has to do with social distancing in pandemics with a focus on an old pandemic of the Spanish flu in 1918. Restricting social ties to family, work, and friends through lockdowns and other sorts of mechanisms during a pandemic might relate to suicide through lessening social integration. In sociology, the greater the social integration, the less the suicide. To the best of our knowledge, there's only one American-based study that measures the relationship between actual days of social distancing, like 10, 20, 30, 100, that kind of thing, and suicide rates, which came out on SLTB earlier this year. We found that a 10-day increase in social distancing, the number of days of such distancing, was associated with a 2.9% increase in suicide rates across 43 cities, the largest cities in the US. However, our previous study had two important limitations. One, it didn't adjust for socioeconomic covariates of suicide and social distancing. For example, literacy historically increases suicide rates, and it may be that the higher the literacy in these cities, the higher the suicide rate. And literacy might be a mechanism which contributed to more days of social distancing. So we need to control for that as well as some other things. So the present study reassesses the link using controls for 5 possible confounders of the relationship. And we also truncated days of social distancing to just days in 2018. We didn't do that. It was a mistake in our previous study. Okay, next slide. Data on suicide rates are from the Bureau of the Census, as are data on just about all of our variables, except for archival data on social distancing. We piggybacked on a group that was studying social distancing and economic growth. And they didn't care about suicide, but it comes from Markle. It was a JAMA article in 2007. And it refers to the number of days of closures of schools, public gatherings like stopping parades and those sorts of things, closing down saloons, and mandatory quarantines. In 1918, here we're restricting it to days in 1918 and relating it to the 1918 suicide rate. The number of days of social distancing ranged from 33 in Newark to 97 in Kansas City, Missouri. So there's quite a bit of variation in the amount of actual days of social distancing. Following previous work, a control is incorporated for the influenza death rate. But in addition, now we add controls for percent literacy, percent elderly, percent white, per capita expenditures on health, and a couple of other things. Okay, next slide. Okay, these are the results of a sort of standard elementary multivariate regression analysis found that adjusting for all of the socio-demographic confounders, each 10 days of social distancing was associated with a 4.6% increase in suicide. The model explains almost half of the variance, 46% of the variance, if you include the percent over 65, which was a good predictor as well, and the percent literate worked out as planned. Okay, next slide. Okay, so the present study adjusts the model in a previous study, Stack and Rocket 2021, for 5 possible confounders, and it restricts the days of social distancing to just days in 1918, corrects for mistake in our previous study. It finds stronger support for the link between SD and city suicide rates. To reach 10 days of additional social distancing, the suicide rate went up about 4.6% instead of just 2.9 in our last study. So tightening it up methodologically actually improved the model. A limitation of the data on suicide is that given the extremely high death rate from the Spanish flu, deaths ascertainment probably took lower priority than usual. We think that these suicide data, like the ones that are coming in right now with COVID, are probably underestimates, given the overwhelming number of deaths that the local coroners and medical examiners had to deal with. But possibly the undercount was random. Present studies seem inconsistent with the conclusion of a recent review of studies on suicide during the presence of the COVID-19 epidemic. However, these studies generally have been unable to measure days of social distancing. They just look at the suicide rate in 2020 and compare it to the suicide rate in comparable months in 2019 and before. They don't measure days of actual lockdown like we do. Caution needs to be exercised in assessing the impact of COVID-19 on suicide rates. Again, due to a likely undercount, and COVID-19 is occurring in a very, very different socioeconomic environment. We have stimulus payments to help people out. We have Zoom, we have telephone. In 1918, the social distancing probably hurt a lot more because most people didn't even have a telephone to talk with other people. There are some recent studies that are starting to find that suicide rates are going up in places like Japan and Hungary in late 2020. And so that this is not actually the only study that's finding a link between social distancing and suicide. Well, that's it.
So, hello everyone. My name is Tatiana Quinto. I'm from Brazil. I am currently linked to Descomplica College through the post-graduation program, and the linking with the Catholic University of Santos occurred during the assistance project I'm going to talk about. So now I'm going to talk about my experience with suicide and self-injury prevention with low-income Brazilian adolescents during the COVID-19 pandemic. So suicide is the third cause of death among people from 15 to 29 years old in Brazil, and the second cause among people from 10 to 24 in the United States, as stated on Pan American Health Organization and the National Institute of Mental Health websites. And according to the World Health Organization, the COVID-19 pandemic has caused an increase in risk factors for suicide, including anguish, anxiety, depression, added to issues of violence, alcohol, drug abuse, and the feeling of loss. Next slide, please. So considering this data, a project was developed in partnership between the Municipal Council for the Rights of Children and Adolescents of Santos in Brazil, and the Association Estrela do Mar linked to the post-graduation program at the Catholic University of Santos. This is an emergency intervention project with the purpose of providing preventive care for low-income adolescents, ensuring the national law for the prevention of suicide and self-injury in the region of Baixada Santista in Brazil. It was developed from January to April from this year in 2021 and assisted teenagers from 12 to 17 years old. Face-to-face and virtual sessions were provided along with artistic processes and Walter Trinka's drawing and story method. These sessions were divided in individual and group sessions. So we had 3 individual sessions for the teenagers and 2 group sessions, one with the families and one with the teenagers to close the assistance. And all this with humanistic psychology and social psychology theoretical background. Next, please. Well, so a total of 123 teenagers from 12 to 17 years old were assisted, and the demands most reported by them during the sessions were related to grief, self-destructive behaviors, and lack of social interaction. During the sessions, many participants said they felt welcomed, listened to, and experienced a sense of belonging. Next slide, please. So some conclusions about the work done. First, we realized that this initiative was very important and significant in the field of self-injury and suicide prevention, and can encourage further work in this area, especially during and after the COVID-19 pandemic. As I mentioned, the COVID pandemic has caused an increase in risk factors for suicide, which needs to be observed and monitored, considering the post-pandemic period, resocialization, return to work, school, and other normal activities. Some challenges we faced during the project. The first one is related to health service and social assistance support, because our project was meant to be a short-term project. So as I said, we had this for these 5 sessions, and some patients, some teenagers, they needed further care. So we needed to send them to these health and social services, but not all of them were willing to receive these referred patients or did not respond to our requests. And another challenge that is not here, but it was very important, is related to the access to internet, because the most part of the project was using virtual sessions, especially Google Meet. And many participants, many patients, they had a very bad internet connection, especially because we assisted low-income families, low-income teenagers. So this was a big problem. But despite these difficulties, the project managed to offer psychological care to the participants, spaces for artistic expression, interaction, and elaboration on feelings. Thank you very much.
I'd like to thank all the speakers for this informative session, and special thanks for the really clear and well-organized presentations. It's a lot to have a sequence of that many presentations and actually end them on time and have a chance for a Q&A session. So let me start by asking all of our speakers to come on with your videos so that you're on when I begin to ask some questions. And I'm going to start with Adam and probably ask a couple of questions of everyone as the questions are available. So starting with you, Adam Horowitz, what are your thoughts about how often these kinds of mood assessments should occur in order to be useful or reliable predictors of outcomes?
Yeah, it's a good question. So it's one of the things that actually we're starting to look up at in a follow-up paper, is to see kind of if there's a certain point in time where the predictive value during that period is no longer valuable, right? So what is the earliest point in time during that first quarter where you have a pretty reliable sense? It might not be kind of the maxed out accuracy, but kind of within a few points, if you can get there earlier and determine kind of when you have that sense and when you can potentially intervene. And yeah, with the study, again, the overall kind of the average completion rate for those in the study was about, I think it was just over 50% with a standard deviation of 20 something. So a fair range, but these predictive values came from folks who were, you know, responding every other day approximately, and were able to have a nice improvement in the prediction of outcomes with just responding to, again, a single item once every day or two is valuable, again, without being compensated, without any of those additional incentives versus some of the more intensive studies where there's 6 surveys in a single day and compensation for each. I think that there's a nice demonstration of the, you know, practical and real world ability to apply that and get some of that valuable information.
You know, you mentioned lightly right at the end of your talk the idea of adaptive interventions and how you might use these data to create a just-in-time or an adaptive intervention. Would you say just a little bit more about that?
Sure. Yeah. So adaptive interventions, particularly just-in-time adaptive interventions, are designed to respond in the moment when there is that detection of risk or signal or anything like that, and using some of that passive data or information that they're sharing, again, rather than like a traditional therapy model where you might be meeting with a therapist once a week or every 2 weeks and things like that, and you kind of have to bring it there using some of those features. And the really nice thing is, right, sometimes folks don't necessarily have that awareness in the moment, and especially if we can improve some of the passive sensing with heart rate features and things like that. I know that there are already kind of watches out there that start to do this, that can detect stress more or less, and then can kind of send a little ping or a vibration to inform you of like, hey, seems like you might be stressed out right now, and then be able to recommend certain strategies or approaches and things like that. So a lot of really great opportunities coming down the pipeline.
Okay, and another one that has come in, given the importance of sleep, what are your thoughts on the implications of your work potentially to inform the residents' work week and work schedules? As you probably know, in others, these are sometimes extremely long shifts and up to as many as 80 hours a week. So do you have some thoughts on that?
Yeah. So another paper that recently came out from the research team looked specifically and identified that it was the variability in like the sleep and wake time in particular that was predictive of depression, right? So it's not always just about how much sleep you're getting, but also matters kind of when you're getting it and the consistency, because we know that if you're, we've all, or many of us, I'm assuming, or those in the States have recently experienced a daylight savings time shift, and everyone's clocks get off and things like that. And in doing shift work, like residencies sometimes have to do with night shifts, can kind of be that experience many times over in a given, months and years. So there's definitely a lot to still discover and figure out in terms of how to help improve mental health outcomes given the challenges with that kind of work.
Okay, thank you. Yoni, you talked some about internal surveys and the importance of including, I think, more demographic data than we have usually included to date. Would you give some examples of the kinds of internal surveys you're thinking about?
Yeah, our work, this particular project was looking at treatment access, but medical students and graduate students in general receive surveys at least once a week from our institution or from student research projects. So we're really gathering a lot. One of the major ones that comes through is the graduation survey that's distributed by the American Association of Medical Colleges, so all medical students across the country. And it wasn't until this past year that they started breaking down that data for schools just by gender and a composite variable of races underrepresented in medicine. So I think that we could really expand on a national level, better collection in that particular survey, and then really rethinking the surveys that we're sending internally, any kind of check-ins. For example, now we do quarterly check-ins at the medical school to gauge the sentiment, but we should really be integrating demographics into that to see our students of color, for instance, having different time points throughout the year in which they need more support, given everything that we know about police violence, for example. They may be experiencing greater stress after, a horrific police violence killing, and that we need to be able to respond to that differently than we would for the general student body.
Thank you. And I think many of us, and probably many of our participants attending, have an interest in the translation of science to practice and the challenges of translating our work into practice. What do you see as how the work you're doing has the potential to change how medical schools approach the well-being of students?
Yeah, and this is really at the core, I think, of where my career is going. I was a social worker before this, and so that was all about practice, and now trying to fill it in from the back end. I think that the theory that we kind of know and talk about all the time is that our identities shape our lived experiences. And we usually keep that in our diversity, equity, and inclusion box. And then in the other place, we talk about how important well-being is for students. And we run yoga sessions and we have reflection exercises, but rarely do we marry these two kind of concepts together. And what I really hope that we're going to start doing is, as we diversify the medical workforce, which we're spending a lot of resources, time, and energy doing, that we're then going to necessarily need to examine sort of these questions by race and gender in a much more active way. I can say that at our institution, one of the ways that we're doing this is we're developing a stressors map of the curriculum to see, are there points where students are experiencing greater stress, and do we have programs or initiatives that are addressing that stress? And now, based on this data, we want to fold in an understanding of women experiencing greater burnout into that, so that we're slightly more specific in the stressors that we're identifying. And so in a couple of weeks, I'll be meeting with the medical school to get ideas about maybe why they think that this is happening. So that's going to fall back on my community organizing training. How do we have conversations? And I know others spoke about sort of community participatory research, which is an exciting model to kind of bridge these two together.
Yeah, it sounds like you are actually gathering stakeholder input throughout the process of your work. So it's not that you're presenting your findings and seeing what they say. It's very integrated. There's some reciprocity there.
Exactly. And I'm not getting the sleep that Dr. Horowitz was talking about.
Okay. Now that may be true for many, huh? All right. Khaled, just maybe as some background for all of our listeners, what do we know about how much living with bipolar disorder elevates risk for suicide?
So pretty significantly, it increases the risk from 10 to 30 times compared to the general population. And some studies quote from 20 to 60% of patients who are living with bipolar disorder attempt suicide at least once in their life. So it's definitely a problem that people that are living with bipolar disorder experience. And as for the reasons, nobody really knows, but it's just something that has definitely been studied or shown to be significant.
Yeah, that is obviously a really large increase. No one really knows, but are there, hypotheses or theories about why that might be?
Well, for the study that I was looking at and the research that I was looking at in regarding to COVID and the suicide rate, there's this thing called long COVID disorder. I think all of us have heard about it. And whenever you see it like on the news and stuff, even people are talking about, like, I still have brain fog, I still have pain, I still have all of these symptoms that are lasting months after COVID. And so one of the proposed mechanisms is that some sort of inflammatory response in the brain combines with the manic episode, which also the pathophysiology of that isn't too well understood, but those two together come and manifest in an increase in suicidality for some reason. As to what the reason is, more research would need to be done in order to really identify that. But that's definitely one of the proposed mechanisms for it.
So are you suggesting that individuals with bipolar disorder may be more likely than other individuals to have certain kinds of negative outcomes from COVID?
Well, yeah, because on top of the actual, COVID infection itself and the long COVID infection that some people persist to have even after they get over the acute illness, a lot of people, depending on how severe the COVID was initially, can develop like PTSD if they were ventilated, if they ended up in a ICU or something. They can develop some sort of acute stress disorder that maybe later turns on into PTSD, which when you combine that with bipolar disorder as well, and an acute manic episode, it's all these variables that come together for the perfect storm that increase the suicidality risk.
And thanks. For many of our listeners who are researchers, I wonder if you would share some about your experience with accessing this massive clinical database and getting comfortable and familiar with it to do your analyses.
Yeah, so I definitely had some, the people that were on that list at the beginning, the authors page, definitely helped me out with that because I'm sort of a novice when it comes to the TriNetX software, but it was really interesting. So based on the codes that you have, you can look up a lot of data and it's all like HIPAA private, all of this stuff is just the raw data that you take and then, you know, you do your analysis and all of that on, and it's pretty fundamentally like, I don't know, it's huge. It's a really, really good software that has a lot of data in it. I think to get access initially, you have to be affiliated with some sort of research or some reason to do it because there's more than just health data on there. But yeah, there's definitely a lot of data on there.
Yeah, a lot of data and a lot of time probably to really get comfortable. It's an investment to begin a project like that.
Yeah, absolutely.
Okay, Lindsey, I was really fascinated by how much you did take a community participatory or a stakeholder approach. And, you know, one thing that came to mind, particularly when you were querying people, their ideas about the training, were you surprised? Were there any surprises in what you learned from stakeholders that maybe you wouldn't have come up with yourself or changes you wouldn't have made?
Yeah, that's such a great question. I think going into this, and this is why we wanted to work with stakeholders. I didn't want to come up with all of the things that we might change. I wanted to hear from people who would be going through the training, delivering the treatment. So I think some of the surprises actually, as a clinician myself, and knowing all of the time constraints when it comes to engaging with training, I thought, you know, a virtual on-demand tool would be wonderful. Everyone can kind of go off in their own worlds, engage with it, and come back and ask questions if they need to. I kind of imagine that people would want to go off on their own and do that. But what we learned, and I don't know if it had anything to do related to COVID-19 and a lot of people experiencing social isolation, providers included, just finding that they wanted more of a community in this virtual training. So like I said, asking about going through in a cohort, meeting with other members in the cohort, doing role plays with one another. I really actually did not anticipate they would want to engage with each other as much. Also thinking about how all of the providers are in one community mental health setting, imagining that they come across each other a lot, not to say that they may be tired of seeing each other virtually, but I didn't really anticipate that they would want so much contact. But I think it really is important, and we think about how virtual training, you know, can live separately from the experience in a workshop or a classroom. And I really think that we've learned a lot in the COVID-19 context, even when it comes to education, about how important it is to build a sense of community, even if it's just, you know, a training that you're logging into or a workshop. I really think that there's a lot of positivity that comes out when you have community. So that's something I didn't anticipate, but I'm so glad that everything was brought up, and it seems to be unfolding well.
Yeah, that's great. One thing that was notable, though, is that all those suggestions actually increase the cost, where many times we want to integrate technology with the idea that it's going to be so, you know, inexpensive, and then they want more booster and they want more live chats. And so I'm just wondering, where do you draw the line? Because I'm guessing you're also interested in scalability.
Yes, that's such a good question. And this is where I feel like, you know, as an investigator, as someone who is developing and implementing an intervention, you want it to be the best it can be. So, here I am saying, yes, of course, I'll meet bi-weekly with you. We'll do all of this, supervision more so than what we had planned on doing. But you're right, that really boils down to effort. Of course, we think about financially where all of that comes from. And then a big piece of the study and one of our aims is on implementation. So we are really focused on how this can really be scaled and used. So I think throughout the process, we're in an open pilot trial right now. So I will say we're getting a lot of lessons learned. And I think that this is the phase before the randomized control trial where we're trying to figure out that balance. So for now, I do think that we may be going a little bit beyond what is realistic in a community mental health setting, for example, but I just think that it'll be a process to calibrate that, because at some point there needs to be some kind of line. And I guess a small example of something I decided yesterday, I actually pre-recorded a video of myself going through the delivery of a treatment for a clinical case, talking about, from the beginning of assessment to even looking at worksheets and showing them on the screen about how I would apply the skills. And that initially started as a conversation of a workshop that I was going to lead. So I think learning about how to make things more feasible, but now here I am needing to edit that video, which we're working through the process, but it's something we're thinking about for scalability for sure.
And then just one more question here. How with online training do we ensure that providers actually have fully engaged in it?
Yeah. Yes, and I think we all can probably relate to this a little bit, having to go through workshops or trainings, and sometimes you might feel distracted by a lot of, competing demands, and you might get to the end of a training and you're like, wow, is there a recording of that? I really want to go back and revisit it. So we really thought about how we could make it engaging along the way, and we have it set up so that it almost unfolds as you move through it. So you can't move forward until you complete, it's 4 modules. So you have to complete module 1. There is a knowledge evaluation. So those hurdles, we have essentially quizzes. So they have to get through the quizzes. They have a certain number of tries that they can take. Then we could set up a troubleshooting, appointment. There we go again with more time. But we have it set up so it's not just this gray space of move through the material. We have a timeline. Everyone gets emails at the beginning and end of every week saying, we're entering week 3. By now you should be working in module 3, then reaching out to the people who haven't started it yet, seeing how we can assist. So it's a lot of managing people moving through it, and then thinking about implementation, right, in a practice setting. Who would be doing this? Who would be, following everyone and making sure that they're actually doing the training? I think the knowledge assessment is probably the biggest piece of the puzzle there, right? You have to go through the training to get as much of the information for the knowledge assessment, especially because it's an intervention so specific to schizophrenia and suicide, where I'll say I don't think there's a lot you can Google on it yet. It's pretty new. So the knowledge piece and those tests are probably the best thing that keeps people moving.
Yeah, no, it has some parallels to all of the online learning, the mandatories we have working in a healthcare system or a medical school, like fire safety, where you have to watch the videos, open every page, and take a quiz at the end. So there's no jumping to the finish line.
Yes, and for the purposes of the intervention, we observe role plays, and there's a fidelity check. So sure, they could sit there and kind of answer the questions that might make the most sense, but at the end of the day, we make sure that they're adherent to the treatment before it's delivered.
All right, thank you. Nicholas, in the patient population that you're working with delirium, do you have thoughts about ways to prevent or reduce suicide risk in this population?
Yeah, so when in particular with COVID-19, I think kind of trying to nip it at the bud, promoting vaccinations, and now that we have booster shots, promoting those booster shots to hopefully reduce the chances of contracting COVID-19 would be the best way to go. I understand like in the current political climate, that might be a little more difficult than we would like it to be. But I found that taking time to listen to the patient's concerns and not totally disregarding them, and actually validating what they're feeling is important, and actually opens up like an avenue for communication. It allows them to listen to you because you listen to them first. And I think a lot of the times that's just what patients want. They just want to be heard and not be told, oh, that's incorrect, right? You shouldn't be worried about that. There's a lot of unknowns, especially when it comes to COVID-19, unfortunately, because there's a lot of information out there, and that information may not necessarily be true. So I think patient education and like clear communication and understanding is important to start that conversation and just promote those vaccines, not force it on anybody, but say, hey, you know, this is probably in your best interest. And I think ultimately it's for your protection. So that's one way that we can prevent COVID-19 induced delirium and suicidality. Another important thing would be to orient patients who do develop delirium. So this is like non-pharmacologic management. If they're in the hospital and they end up having like fluctuating consciousness, they're not completely oriented. I remember actually in one of my rotations, seeing a patient one day, they remembered me, we were having a conversation, and the next morning they actually forgot who I was. And I had been seeing them for 5 days at that point. So things like that, where they seem to become disoriented or forget things, could suggest delirium or suggest some sort of alternating level of consciousness, and things we can do to prevent that, like, you know, just kind of reminding them who you are, opening up the windows to let them know, hey, you know, it's daytime versus nighttime, reducing noise and reducing, I guess, too many personnel in the room. That way they don't get too flustered or confused. I think those are important ways to kind of reduce or help to manage delirium and reduce the suicidality associated with it.
What are some of your thoughts about reasons or explanations for why there is an increase in suicidality with this COVID delirium?
So that's a good question. So this actually kind of reminded me of patients. It's a similar patient population, and I've seen this as well, where patients who survive cardiovascular events like a heart attack, eventually a few months down the line, that heart attack could have been a very traumatic event for that patient, and they could have been very close to dying. It could have been a near-death experience, and that could lead to certain mood disorders, in particular depression. So I think something similar might be going on with this patient population, since COVID-19 is a scary thing for a lot of people, I think for everybody, especially with, you know, I think it's almost like we hear somebody that we know of, you know, every day getting COVID-19 or having to get a test because they might have been exposed. And it's, people kind of almost treat it like it's a death sentence right now because it is a very dangerous infection. So I think the trauma related to that, the fear related to having COVID-19, and then being a survivor and remembering how traumatic it was, because a lot of these patients have to be put on ventilators, and it's not an easy process, and there really is no definitive cure. All of that fear and trauma could relate to mood disturbances later down the line.
Yeah, thank you. It's a lot to, it's complex. There's a lot of variables coming into play there.
Yes.
Thana, I have a couple of questions for you. Can you, I really appreciated, you know, bringing artistic processes into our notion of healing and mental health intervention and prevention. I wonder if you could say more about the artistic processes and what actually happened in the group sessions.
Okay, so our idea was actually, well, as I said, we have the theoretical background of humanistic, social psychology, so that's why we usually work not with a directive methodology, so we wait for the patient to bring up what they want. But the artistic process in that case worked as a tool for what the patient wants to bring up for the sessions, for the group sessions. So in the first 3 sessions that they were individual, the teenagers, we asked how they were feeling. They brought up the topics that they want, but also we used the Walter Trinka drawing and story method that consisted in us bringing a topic for them. And then they had to draw, and after that create a story about that topic, related to the drawing. So this was the first part that we used the art as a tool. And in the group sessions, at first we had some in-person group sessions, and then we had group for 3 hours straight. So we used a lot of art. We provided a lot of materials. They used abstract drawings. They learned a little about abstract drawings. We also provided topics like, for the families, how were for you being a teenager, and how is being now an adult, how is being an adult in pandemic, and for the teenagers, also how is being an adolescent during the pandemic. And they used the art to talk about that. So they put the feelings, everything they want in the drawings. But in the virtual sessions, in groups, this was more difficult. We provided more art materials and tools during the in-person sessions when I'm talking about the groups.
So then how did that transition work to the virtual sessions, virtual groups?
Yeah, at first we had the in-person because we had a low number of cases. It was in the beginning of the year here in the region. But then the numbers increased. We had the lockdown again. The NGO that we were working at had to close. So we already had the individual sessions virtually, but the group sessions we had to adapt for the virtual. At first was a little hard because we prepared the groups for the in-person, as I said, for 3 hours for the materials that we provided, and the virtually we could not provide materials. And now that I'm saying this, I think that it would be very nice to have some tools online, so to use technology to do that. But as the preparation was for the in-person, we didn't have at that moment. Then it was a little hard at the beginning. We had to adapt to understand that we could not stay for 3 hours in a virtual room with people that are not used to it. Also, as I said, they were from low-income families with connection problems, and we noticed, especially with the parents, that they were in the session, but they were watching TV, they were talking with a neighbor. So we also had this problem at first for them to understand that moment was the opportunity they have to talk about themselves and whatever they want about the pandemic. So the transition was a little difficult, but I think we could understand how it could work.
Mm-hmm. Would you share some about what you see as the next steps in what you're doing?
Yeah, this actually, sadly, this project is not continuing anymore because we didn't have financial support for that. We are in a team of 3 psychologists. 2 of them are in the master degree, so they are having a research about that. So probably the continuing for them is going to be different than mine, because I am trying to share the experience of how that was, because I think it would be interesting for other scientists, other researchers to reproduce that project in different regions with different public. So that's what I'm doing. But they are in this project in the master degree, and I imagine they are going to try to continue this project somehow, but we are trying to find some financial support for that.
And I think that's a challenge that we all face at different times, is the financial support to keep the work going and moving forward. I wonder if you have thoughts about research questions related to some of your work.
Sorry, I think I didn't understand.
Yeah, in terms of evaluating, in what ways this method of intervening is helpful to the young people. Ideas about what the questions might be to figure out how is this working?
Mm-hmm. Yes. Well, as I noticed, I really see that they were needing this, how can I say, this project to be listened to and to have a approximation with people, because with the social distancing, this was very difficult for them. As I said, they went through a lot of difficult situation. Grief was the main topic for them, for the teenagers. So they really needed this kind of support, especially because, well, as I said, it probably going to change from region to region. Here where we made this project, we were facing problems with the health service, as I said, and social services. So they were focusing a lot on the COVID problem, and the mental health was really forgotten. So they were not having mental health support, and they could not pay for private support. So I think this project was really handy for that case. As I said, I think now with this post-pandemic period, I think we are going back, we are starting to see people again, return to school. I think this might be challenging also, because if we think, for example, a teenager that was suffering bullying, now they have to go back to a place that is not safe for them. So I really think this moment is also important for us to pay attention.
Thank you. And I want to thank all of you for participating in the Q&A and sharing your thoughts with our audience, our attendees today. We're going to wrap up with just some concluding comments here. First, I just want to thank not just our presenters, but I also want to thank everyone for joining our second annual Injury Prevention Center Research Symposium, which was virtual. Thanks to our presenters, to our staff, Lynn Massey and Lisa Orson, for making sure today's session went smoothly. They really were working in the background all day. All of our attendees, you'll be receiving an evaluation survey within the next few days. We encourage you to fill it out to help us continue to grow and improve this event for future years. Please also fill out this survey so that you can request continuing education credits. And additional information about this can be found on our Injury Prevention Center Symposium webpage. If you're not already a member of our Injury Prevention Center, we invite you to go to our website. It's at injurycenter.umich.edu to become a member and get access to our monthly newsletter that has publications, updates, and information about events. Please also check out our website for more information and opportunities that might interest you or your colleagues. We have a summer internship program. We have massive open online courses. And as a reminder, all of our sessions today were recorded and will be available on our website in the coming weeks. Thank you again for your attendance. Thanks to all our presenters for their important work in injury prevention. Really enjoyed it. What a varied session. Learned a lot and really engaging. I hope everyone has a great rest of the day. Thanks very much. Bye now.